it away.
Thanks. So I'm Michael. I'm one of the first-year Retina fellows here, and I have grand rounds that I've titled The Usual Suspects. Jumping right into it. Okay, so we have a 25-year-old male here referred to us for urgent evaluation of blurry vision in his left eye for the past 3 days. Says he woke, vision's been blurry, no real change since its onset, hasn't had any episodes of transient vision loss, no postal tinnitus, no double vision, no eye pain, flashes, flutters, trauma, fevers, chills, etc. On his initial exam, the vision on the right eye is 20/20. The left eye, which is the affected eye, is 20/30 plus 2. Pressures are normal. There's a faint but present afferent pupillary defect in his left eye, and his color vision is measured slightly less in the left eye relative to the right eye. Here's a fundus photo of his right eye. I don't know, are there any residents on already who want to take a shot at describing the right eye?
Sure, one of the first years I know would like to take a stab at it. I can pick one or you can pick yourself. All right, Lucy, take a shot at it.
So it looks like an Optos photo of the right eye. Just looks pretty normal. Macula looks fairly normal. I'm not really seeing too much abnormal in this.
That's perfect. It's a normal eye. Contrast it. This is the other eye. Take a look. Describe that eye for me.
So an Optos photo of the left eye. Disc margins are pretty blurred. Looks like maybe some disc swelling, maybe a little pale as well. There are some hemes kind of peripapillary and out into the arcades as well. Some like more pale areas kind of following, coming out from the disc as well.
Yep.
Yeah.
Very good.
Perfect. Yeah, so there's definitely 360 degrees of obscuration of the disc margins. There's this sort of yellow-white opaqueness to the retina that's going from the disc, tracking along the arcades and radiating out from the peripapillary area, involving the macula and even the fovea temporally. And there's hemorrhages all along the periphery there, so that's perfect. Are you able to see my cursor if I move the cursor around?
Yes, yeah.
Okay, great. Okay, here's the autofluorescence of the right eye, which is normal. Here's the left eye, which helps highlight those changes that Lucy was describing. And you can see that there's these areas of hypoautofluorescence that correspond to the yellow-white areas of the retina, and some also darker areas of hypoautofluorescence that correspond to the hemes that were there. Great. So this was our description of the exam. The only thing that we couldn't capture there is there were a few cells in the anterior vitreous in the left eye, but other than that, spot on with the description. And we actually got a visual field. And does anyone want to take a stab at trying to describe what they see with the field?
Becca, go ahead.
Okay. Looks like it's a pretty reliable test for both eyes. It's a 24-2. In the left eye, there's some temporal depressions that basically respect the midline. A little bit above is superiorly, it crosses the midline. And then in the right looks pretty normal.
Yeah, that's cool. I think the main thing that the field shows is that there's enlargement of the blind spot there, which would correspond to this sort of process that's occurring around the optic nerve in the left eye. So, and like all good retina specialists, we got an OCT through it, and you can see there's a pretty significant difference between the two eyes. Anyone want to try to describe the OCT?
Val, you look like you want to describe the OCT. Go ahead.
Okay. So it looks like on the left eye, the right eye looks normal foveal contour. On the left eye looks like there's some disorganization or swelling of the inner retinal layers. There, and more so even nasally. There's some maybe there's like an area right under the fovea that's kind of hyper. Sorry, I can't think of the word right now. Sorry, and then there's.
Are you talking about the area that's bright under the central fovea?
Yep.
Yeah, it's okay if you don't know what the findings are. You can use descriptors such as thick and thin or bright and dark.
Okay.
I notice you use a term swelling. I think it's fair to say that there is thickening in the left eye, particularly nasally, mostly of the inner retinal layers, and they're very bright. But interestingly, there are no pockets of fluid that are present in that area of abnormality.
Yeah.
Michael, was there anything else you want to add?
The only other thing is that you can see there are a few little hyperreflective foci in the vitreous here, which would correspond to the vitreous cell that we were able to see on exam.
Very good.
Here's a montage of the fluorescein angiogram we got. I don't know if there's a way for me to. I'm just gonna go back. Okay, so cycling through here. I'll play through it one more time. So, anyone want to try to describe what they see with the fluorescein?
So Lucy, does that fit with what you saw in the fundus picture when you were looking at that? What did you expect this fluorescein?
Yeah, I think so. Looks like pretty extreme swelling of the disc, and then the associated retina coming from the disc as well. Quite a lot of leakage from the vessels too.
So let's go back, Michael, to the early fill image. There we go. Okay, so we have an early filling phase here, and these are zoomed out, so I know it's hard to comment on detail, and also there's some media opacity that makes it hard to answer a lot of the questions that we have. Was there blocking, Michael, of any kind, or is this just absence of filling in this very early phase angiogram?
There is a little bit of blocking that corresponds with the areas of hemorrhage, but other than that, it's mostly, and perhaps there's like very subtle blocking where there were some of those sort of white yellow areas, but for the most part, it's media opacity that's making it a little hazy to see.
Right, so you have the thickening or the white opacification of the retina that's present in the peripapillary region that may have very minimal blocking, and then later stains and leaks. And then would you just point out the areas of blocking defect for folks so that they could see those in correspondence with the retinal hemorrhage?
Yeah, so you can see them pretty nicely on this one here. So
there you go.
There. These little spots, mostly in sort of the edge of where that sort of white opaque area was.
So actually this image here, I think nicely shows some of the opacification or blocking of fluorescein transmission. Yeah, right there, inferior to the disc. So you've actually lost resolution of details of the retinal vasculature. And then it becomes overwhelmed by fluorescence later in the study.
Exactly.
Here we go.
Mike, I think an important thing here also is, when you're looking at this, and we'll get to the differential here in a second, just thinking ahead, one thing to, look at is whether you think there's vasculitis there or not, as you're thinking through a differential. What do you guys think in terms of that question? If there's any significant vasculitis, we actually have a lot of things that appear white. Here at the end, there's some leakage of the dye, but do you think there's true vasculitis?
Comments, what do you think?
Maybe out like temporally, you can see little areas of hyperfluorescence around some of the vessels, a little bit of leakage, but it's not like a classic like ferning type appearance or something like that. It doesn't seem like there's a lot of vasculitis.
Yeah, I agree. It's not what you typically expect to see with a vasculitic process.
Yeah, one of the things that really jumps out to me in contrast to our more typical inflammatory picture is that even the areas that appear normal on fundoscopy, on the fluorescein angiogram, if you have a panuveitis or a fairly intense posterior uveitis, typically I would expect to see more hyperfluorescence in the far periphery. Fernando, do you have any other comments on this angiogram and the imaging so far?
There is an area, one of the frames demonstrates areas of the vessels that we're not filling. Can you go back a little bit? More there. So these areas of filling, how many minutes are we there? How many seconds?
This is pretty early. There's not a timestamp on it, but this is within about 30 seconds.
Okay. So just arterial. All right. Okay. All right. So nothing else than what has been commented so far. I mean, this looks like a posterior uveitis, and the first thing that I would do is to try to rule out infectious causes of posterior uveitis. How old is the patient again?
25.
25. So my typical workup for these patients would be to rule out toxo, TB. I get an HIV, and I want to know if they have syphilis. I always rule out syphilis in all cases of posterior uveitis. Other things that I would like to rule out is sarcoid. I don't see anything, did not hear anything on the medical history that could lead me to other things, but I would like to question the patient about symptoms of Behçet, for example, lupus, just to be thorough. But in general, before starting any treatment, I would definitely rule out an infectious disease. It's the most important thing before starting any anti-inflammatory medication. Let's see. Can we go ahead on the fluorescein angiogram a little bit more? Yeah.
What about that right eye? We haven't commented on that. It looks to me, just in this single image here, are we just getting a very peripheral view, or is there a little bit of non-perfusion in the periphery? Michael, the vessels don't look entirely normal.
Yeah, I think that it's possible there might be sort of subtle non-perfusion out there. This is a very peripheral view, and within the realm of wide field Optos FA. This could be, an extreme variation of normal, but definitely the vasculature seems to end rather abruptly.
Yeah, I mean, I'd be interested to know a little bit more about the patient. Was there anything else you wanted to add to the differential, Michael?
Well, we did a pretty good job of covering most of the stuff that was there, and this was sort of the basic working differential that we had. Sort of infectious stuff was at the forefront. Always have to think about inflammatory things, and of course you could always consider neoplastic causes like leukemia. One thing I remember when looking at this patient initially is that the area of sort of retinal whitening and that sort of retinal infiltrative area seemed to go into the macula and into the fovea, but his vision was still relatively well preserved, which was odd, and it's not something that you would typically expect to see in like a necrotizing retinitis, like a viral retinitis or an infectious retinitis. And so that made us pause and scratch our heads a little bit about what.
You could, if the patient, for example, is HIV and has progressive outer retinal necrosis, and they tend to respect the posterior pole, initially, and then extend all around the periphery, and patients can have good vision at the beginning. So it is a good idea to check for maybe take a sample and do PCR for CMV, varicella zoster, and herpes simplex.
Absolutely.
And Michael, my only other question for you on clinical exam, since we're relying right now just on Optos photography, and we all know that color saturation on Optos photography is imperfect at best. How white was that posterior plaque or infiltrative area?
It's a good question. It was, I would say it was more sort of a yellow-white appearance than truly opaque white.
Okay. All right. How did you approach the patient?
So what we ended up doing is there was, when coming up with this differential, there was one key piece of the history that I didn't mention just for the sake of coming up with an interesting differential. And that was that he did have a history of T-cell acute lymphoblastic leukemia that was diagnosed back in 2018. He was treated with several chemotherapy regimens, did achieve complete remission in 2019. And then he's been on maintenance chemotherapy since then, and he's on his cycle 6 of maintenance. He's had a lumbar puncture as recently as a month ago that did not show any evidence of any CNS disease, and he's not considered significantly immunocompromised right now. He is taking acyclovir and Bactrim as prophylaxis. And so what we ended up doing is, so we didn't really think he was greatly immunocompromised. We tested for syphilis. We looked at his recent LP, and we did get an MRI, and the MRI was read as essentially normal, except for this helpful arrow sign that was given to us by radiology, where they said there's maybe some subtle signal abnormality along the posterior part of the eye that corresponds to the retina and would correspond with our exam. But other than that, they didn't see any abnormal enhancement of the optic nerve. They didn't see any other intracranial process going on.
Can I ask something about the progression of these lesions? How long had the patient had the symptoms, and what is your sense in terms of how rapidly these lesions were progressing?
He said that he woke up in the morning and the vision was blurry, and that was 3 days prior to presentation, and since he noticed that the vision was blurry, he has not had any change in the vision.
And you've been following the patient for how long, and did you see a lot of changes rapidly or not?
So this was our first time seeing him. We hadn't seen him before. So this was first exam.
Okay. Because a lot of patients that are on chemotherapy for different things, including leukemia, develop CMV retinitis. So most of the cases that we see with CMV retinitis are patients that are on immunosuppressed for other reasons other than HIV. So this could be the case.
Definitely. So at this point, sort of what to do next. And we wanted to try to figure out exactly what was going on. And given his history of leukemia, we were slightly worried that this could represent leukemic infiltration of the optic nerve and peripapillary retina, but we were worried about a viral retinitis or other causes of infectious retinitis. And so what we opted to do is we actually proceeded with a diagnostic vitrectomy in this case. And I put together just a very quick video to show most of the residents what we do for a diagnostic vitrectomy. And this is essentially a standard 3-port vitrectomy, but when we do the initial vitrectomy, we do it all under air. So the infusion is set to air, and we disconnect the aspiration line from the vitrector handpiece, and we have usually a 3 cc or 5 cc syringe on the handpiece, and we're using that to provide the aspiration. And by having the vitrectomy done under air, you're preventing your sample from being diluted, because we wanted to send this sample for viral PCR, for cultures, for aerobic, anaerobic, and fungal cultures, and also to send it for cytology labs just to see if there's any possibility that this represented a local recurrence of his leukemia. As you can see here, we're mostly under air. There's not much vitreous left. We're just taking out the last little bit of vitreous, and then you complete the vitrectomy sort of as normal.
Question for Michael and for Dr. Mathias as they perform this vitrectomy. So one of the challenges in doing diagnostic vitrectomy is that you have a limited sample volume for the undilute specimen, which you obtain when you have an air infusion. And then once you switch to a fluid infusion, obviously you can take more dilute specimens. So it's really important to prioritize the diagnostic tests that you order. And that requires a lot of coordination with the rest of your surgical team and the nursing staff to make sure that labs are sent appropriately and also timely to make sure that they are processed well. So how did you prioritize the tests in this particular case, given the broad differential?
Scott, for the key here, I think is to recognize that any PCR tests you're sending don't require a huge volume, right? So when we're talking about sending viral PCRs, we can have a small volume sample. Cytology is the main thing that we want an undiluted sample for, to try to maximize, if you recall on the exam that Michael showed, there's 2+ vitreous cell that we saw, and there weren't any anterior chamber cells, but it wasn't dense vitritis by any means. So we have, some cells that are within the vitreous cavity, but it's not a lot. So we want as large a sample as possible for cytology in particular. And this was also sent for flow cytometry as well.
Mm-hmm. Good.
So just to comment about the vitreous biopsy, I do it a little different. I like to take an undiluted sample first so that I can take as much undiluted as possible. But then I turn to air if the eye collapses to get a little bit more sample, but it's still undiluted. So I don't open the infusion line until I get all the sample that I need. Because the comment about not diluting the sample, I think is important to get a better yield to make the diagnosis that you want.
Yeah, it's a great comment. And one of the things for those who are performing these biopsies that you have to do, usually your surgical tech will have already primed the line. So there is a little bolus of fluid that's in the infusion line. So if you truly want undilute sample, which is most useful for cytology, and also any lab value that is a continuous variable, such as interleukin 6 or interleukin 10, needs to be sent undilute. If you choose to infuse with air, you have to make sure that the entire infusion line is cleared of any fluid before getting started, or you can simply vitrect as Fernando does, just being careful not to flatten the eye.
And the other thing is, I'm sorry. The other thing is to be in contact with a pathologist beforehand so that he knows the samples are coming. You don't want them sitting there until the next day or something like that. So that coordination is very important as well.
Yeah, and I was going to say, in this case, and if it wasn't obvious at the beginning, Scott, we did exactly that. We cleared the infusion line of any fluid prior to inserting that into the trocar, so that when we did go to air, there was no fluid being infused that was already in the primed line. I do that in anticipation when I know I'm going to need a large volume, and initially we vitrect and take as much of a sample when the eye does start to get soft. That's when we turn the infusion line on and insert and infuse air into the eye so we maintain pressure.
Great. What'd you learn, Michael, from the vitrectomy and the specimens?
Alrighty. So our viral PCRs were all negative, as were all of our aerobic, anaerobic, and fungal cultures. The patient had a repeat LP and a bone marrow biopsy the same day of the surgery, both which didn't show any evidence of recurrence of his leukemia. The only thing that ended up being, not completely normal was that the flow cytometry was inconclusive. There was a phenotypically atypical population of cells that was concerning for leukemia, but it wasn't a slam dunk. They also did a FISH analysis, and FISH analysis was looking for a 6q deletion. but they had a very small specimen sample to work with, and so they weren't very confident, even though it was negative. So overall, as we sort of decided to try, how do we put everything here together, the flow cytometry being not normal and perhaps suggestive of leukemic infiltration, but not a slam dunk either, but none of the other infectious labs were positive. We thought that most likely this did represent, as far as we could tell, a leukemic infiltration. And so what I'm going to do is I'm going to talk just a little bit about leukemia in the eye, and then sort of get back to what unfolded after our biopsy.
Hey, Michael, did you guys check an IL-6, IL-10 ratio?
That's a good question. I do not believe we checked an IL-6 out.
Because you could have also checked that. I know it's always difficult on a low cellularity sample, since he didn't have a lot of vitritis, to get a positive pathology flow cytometry result. And with T-cell lymphoma or leukemia, you can still have elevation of IL-10, which would also help support further diagnosis. And it's an undiluted 0.3 sample of IL-6 and then IL-10, and you can just send that out to ARUP for analysis.
Awesome, good to know. Any other comments before we go forward a little bit? Alrighty, perfect. So again, thinking most likely this was going to be a representation of a leukemic infiltration, I'm going to just talk a little bit about what that is and sort of some important teaching points about it. So when we talk about terminology with leukemia in the eye, there are a few different things. There's this concept of leukemic retinopathy, and leukemic retinopathy generally refers to the secondary effects of leukemia on the eye. So things like the effects of anemia or thrombocytopenia, or even secondary infections or medication toxicity. This is in contrast with leukemic infiltration. Leukemic infiltration is when there's actually malignant cells that are infiltrating and getting inside the eye, and they can infect they can affect a lot of different parts of the eye, from the optic nerve to the retina, to the choroid, to even the anterior chamber. And then there's another entity when you read about sort of leukemia and lymphoma in the eye is primary intraocular lymphoma, sometimes called primary vitreoretinal lymphoma or primary CNS lymphoma. Primary intraocular and primary vitreoretinal lymphoma are the same thing. They're both considered within subsets of primary CNS lymphoma. And that is different than sort of what I'm focusing on, what we're talking about. Really, leukemic retinopathy, leukemic infiltration are a little more linked. So leukemic retinopathy, again, is considered more indirect involvement of leukemia on the back of the eye. And you can get retinal hemorrhages, you can get rot spots, you can get cottonwool spots. You can get hyperviscosity, especially in chronic leukemias, and that can actually lead to a secondary central retinal vein occlusion. And these are just some illustrative photos taken from the UNIZI Atlas that are, good illustrations of leukemic retinopathy as it's affecting the back of the eye. The most common thing that you'll see in the back of the eye in leukemic retinopathy is typically retinal hemorrhages. They're present in somewhere between 24 to 42% of people at the time of diagnosis of leukemia. Other things like rot spots are less common, about 11% or so. However, leukemic retinopathy is not exactly the main focus of what we're talking about, but it is still very common. This was a nice series that was done at Hopkins where they showed that about 80% of people who have any form of leukemia will have some evidence of leukemic retinopathy in the back of the eyes, a little more common in people who have acute leukemia versus chronic leukemia. This is in contrast with leukemic infiltration. Leukemic infiltration represents direct, again, invasion of various ocular structures with leukemic cells. This is an example of preretinal leukemic infiltration. Here's someone who has some inferior disc edema and the leukemic infiltration that's tracking sort of in the inferior retina and along the vessels. Here's an example of someone who had leukemic infiltration of the optic nerve, along with cottonwool spots and hemorrhages, and actually a secondary central retinal vein occlusion. And again, here's our patient who has 360 degrees of disc edema and this peripapillary, what we believe is leukemic infiltration of the retina. this is a really confusing table here, but I don't want to go over everything here. The main point is that leukemia can get in pretty much any different part of the eye and can cause a lot of different things, ranging from orbital symptoms to even a pseudohypopyon in the anterior chamber. People think that the most common place that you would see leukemia in the back of the eye and leukemic infiltrate is actually subclinical choroidal involvement. And there are isolated case reports of people who have choroidal infiltrates. They get overlying serous retinal detachment. Optic nerve involvement like we have is relatively rare. One question is, why do people tend to get leukemic recurrences in the eye in general? And there are two different theories. One is that when people have acute lymphoblastic leukemia, there's a, without doing prophylactic treatment of the CNS, there's generally a very high recurrence rate of CNS leukemia, which has a very, very terrible prognosis. And so oftentimes brain irradiation and intrathecal chemotherapy are given even without evidence of CNS disease, just to try to prophylax against development of CNS leukemia in the future. And so when they're doing the brain irradiation, they actually shield the eyes in orbits because they don't want to lead to radiation retinopathy or optic neuropathy. And so it's thought that because they're not prophylactically irradiating them, perhaps there's a small amount of leukemic burden that's not getting treated. Similarly, there are a lot of studies that show that intrathecal chemotherapy does not penetrate great into the optic nerve or into the eye. And so again, they might consider the eye, quote-unquote, sanctuary for leukemic cells. One question I had is, if there is leukemic infiltration in the eye, is there a higher likelihood that you will have CNS involvement? And the answer is yes, but not 100%. This study here looked at a whole bunch of different people with different types of leukemia, and the important thing is that about half of them ended up having CNS lymphoma. Sorry, CNS leukemia, not lymphoma. I'm just looking at the time here. I'm going to kind of speed through this the best I can. When we look at the treatment modalities for someone who has leukemic infiltration, it comes in primarily two flavors. You can either use radiation or you can use intrathecal chemotherapy. Radiation is nice because it works quickly. You can design the radiation protocol quickly, and you can even use it in people who are chemotherapy resistant, and you don't have to worry about it if patients are cytopenic. A typical course is typically about 20 gray over 1 to 2 weeks. You can also use intrathecal chemotherapy. We tend to use methotrexate in a lot of the current protocols. Even though intrathecal chemotherapy doesn't necessarily reach the optic nerve in orbit in great concentrations, the sort of isolated case reports that describe the treatment of this have found it to be relatively, what did I do? I did something. There we go. I don't know how to fix it. Anyway, the isolated case reports looking at the treatment of this have found it to be relatively effective. There's not great large randomized control trials on how to treat leukemic infiltration in the eye, mostly just case series. Another thing, if you look at the literature, is the idea of using a stem cell transplantation in people who have evidence of proven CNS disease, of which leukemic infiltration may or may not be the harbinger of CNS leukemia. And a lot of protocols now use stem cell transplantation and doing a bone marrow transplant, and that's because it dramatically reduces the amount of chemotherapy and the amount of radiation that is required in order to successfully eradicate the leukemia. In our case, since we didn't have any evidence of involvement in the bone marrow and no evidence in the lumbar puncture that we did, we had what we thought was mostly an isolated ocular case. And one question we had, is there any treatment for just isolated ocular involvement? And there is this study here, and there's one other case report that looked at someone who had anterior uveal and anterior chamber involvement, and using intravitreal methotrexate. In this study, they ended up looking at 6 eyes who received 400 micrograms of methotrexate over the course of a month or so. And they found, importantly, that pretty much all signs of infiltration and direct malignant cell infiltrate and any cell or vitritis all resolved after it. So it opens up the door for potentially using methotrexate for isolated ocular involvement. And I did mention primary intraocular lymphoma, not exactly related to what we're talking to, but I just wanted to mention it because you'll often at least I found these to be very confusing when I was learning about them as a resident, is that primary tract lymphoma is really a subset of primary CNS lymphoma. It's usually diffuse large B-cell lymphoma. A moderate amount of patients who have primary CNS lymphoma will have PIOL at the time of diagnosis, but it's conversely, if you have PIOL or primary vitreoretinal lymphoma, you are very likely to develop primary CNS lymphoma.
One brief comment on the distinction between leukemia and lymphoma in the eye. That typically leukemic infiltration in the eye, as in this case, is a recurrence or an extension of more widespread disease. Whereas it's important to remember that B-cell lymphoma, and there are non-diffuse large B-cell lymphomas as well. We don't have time to talk about them. But the primary intraocular lymphoma or vitreoretinal lymphoma is a B-cell lymphoma that often is originating in the eye. So it takes you down a very different diagnostic workup path.
Absolutely. So going back to our...
Can I make a comment before you go on?
Oh yeah, absolutely.
I thought it was very interesting that patients with isolated leukemia infiltrates can be treated with intravitreal methotrexate. I haven't done that. I have used intravitreal methotrexate for lymphoma, and they used in the publication that you showed 0.1 ml. So 400 micrograms in 0.1 ml are associated to higher reflux. And these patients have a lot more complications because of the irritation of methotrexate on the surface of the eye, corneal edema, and it's a little bit more irritating for that reason and more difficult to tolerate. So what we do is have the pharmacy prepare the 400 micrograms of methotrexate in 0.05 micrograms, ml, I'm sorry. And then when we do that, the reflux is minimal. We still irrigate the eye very well, and the complications on the surface of the eye are much less, and it's more tolerable. So just a little tip on if you can have the pharmacy prepare on a smaller volume, I think it's going to be helpful.
Alrighty. And I think we were able to prepare ours in 0.05. I think.
Okay.
Yeah, that's correct, Michael. We do it in 0.05, and that's a very great comment, Fernando, because the number one, side effect of intravitreal methotrexate is keratopathy, corneal irritation. And so anything that can be done to minimize reflux as well as rinse the eye out very well to minimize the irritation of the cornea is important.
Perfect. Okay, so getting back to our patient here. So again, we plan to do local therapy with intravitreal methotrexate. There was no evidence of any CNS or systemic involvement, and it's difficult to commit to doing, radiation or chemo or even a bone marrow transplant without any evidence of disease that's outside the eye. We did talk to the patient about doing a retinal biopsy for further confirmation of the diagnosis, but it had a very high risk of morbidity and vision loss, and we didn't necessarily recommend it, and they did not want to proceed with it. Intravitreal methotrexate, as we said, has been used to treat intraocular lymphoma for a long time, and so we thought that it had a relatively low risk, again, keratopathy being the main thing that we wanted to watch out for. And so we opted to proceed with local treatment with intravitreal methotrexate.
Michael, can I just stop you right there real quick? This was hours of conversation between myself and his hemonc team, as well as pathology. This is a big decision. Where do we go from here? And having a vitreous biopsy that is suspicious for leukemic involvement, but they weren't willing to hang their hat that this was definitely recurrence, put us a little bit in a difficult spot, especially since his lumbar puncture was negative and there was no other evidence of CNS recurrence. But we were highly suspicious that this was leukemia for everything that you mentioned before. The hemonc doctors did not want to commit to radiation therapy. We discussed that. They certainly didn't want to give him systemic chemo or a bone marrow transplant at that time. the only reason a retinal biopsy was brought up was because I told them that that's really the only way to really, go back in and get another sample that could show you that. But we all agreed that in this case wouldn't really be a good idea or indicated. So that's why we ultimately decided to go the route of intravitreal methotrexate. Okay, keep going. Sorry, I knew we had a lot.
And so exactly after that conversation, we were getting ready to do our first methotrexate injection. And this was a week after the vitrectomy. And we took a look in the back of the eye and we're like, that looks a lot better. What happened? What do we do? We just did a diagnostic vitrectomy. We haven't done anything yet. Dr. Mathias was in the scratching his head trying to figure out exactly why it suddenly improved like that without doing anything. And we went back, we looked through the records, and we found that during the lumbar puncture that he got the day of the vitrectomy, after the vitrectomy, he got intrathecal methotrexate. And he got that because the protocol he's on for the maintenance calls for intrathecal methotrexate at the time of LP on the first day of every month that the cycle starts. And so that was his regularly, he had one other intrathecal methotrexate a month before, and he had one, the day that we did the vitrectomy. And that was kind of an interesting point because we, and helped perhaps confirm that this might represent leukemic infiltration, given that it responded and got better after one dose of intrathecal methotrexate. So we decided to proceed with local therapy. We did the intravitreal methotrexate, and shortly after, within about a week or so, he did have a large volume LP that was repeated. And unfortunately, the large volume LP, this was orchestrated by hematology oncology, did have an atypical population in it that overall, plus the eye findings, was concerning for a CNS relapse of his leukemia. And so ultimately what ended up happening is we did proceed with treatment locally with intravitreal methotrexate, but with this finding of the large volume LP, there was more evidence and enough that hematology, oncology, and radiation oncology all felt that this did represent truly a CNS recurrence of the disease with local ocular involvement as well. And they did recommend doing a bone marrow transplant along with chemotherapy and radiation. But he did elect to complete about 1 month of intravitreal methotrexate injections, doing 2 the first week, I believe, then every week thereafter. And this is his OCT, again, a presentation, and this is about 1 month now after the vitrectomy and after doing intravitreal methotrexate. And you can see that that infiltrative process in the retina has nearly completely resolved. His vision improved to 20/25, and he's planning to get a bone marrow transplant along with chemotherapy and radiation. And so in summary, main teaching points were, again, leukemic infiltration is the direct ocular involvement of malignant cells. Leukemic retinopathy is different. It's more the ocular sequela of stuff like thrombocytopenia and anemia. Mainstay therapy is going to be radiation and intrathecal chemotherapy. However, intravitreal methotrexate might be promising for just local control of leukemic infiltrate if there's no other disease in the body. So thanks to everyone who's involved in this case who helped put together the presentation and helped see this patient. These were my references, and take any other questions.
Great presentation.
Nice case, Michael.
Yeah, great case. Thank you, Michael.
Thanks.